Hello dear students. Today we are going to talk about the colorectal polyps, polyposis and benign colorectal lesions. Colorectal cancer, as you know, is one of the commonest cancer in the body. And among the important causes of colorectal cancer are the colorectal polyps. There are different types of colorectal polyps, but only the neoplastic ones, or the adenomas, are the precancerous. We have to know these types of polyps, their pathology, their pathway, their malignant potential, also their presentation, which is vague, and the investigations to diagnose the colorectal polyps. We also have to know the management of all types of polyps, whether solitary, multiple, or very numerous, and the surveillance plan for the patients after treatment. Also, we have to know the polyposis syndromes and their management. What is the meaning of a polyp? A true polyp is a lesion that arises from the mucosa and protrudes into the lumen of the viscus. It can be a viscus in the GIT, or the urinary tract, or the respiratory tract. Colorectal polyps, as all GIT polyps, may be sessile or pedunculated with a stalk. Some lesions arising from the submucosa, like the gastrointestinal stomach tumor or lipoma, may elevate the mucosa, giving the appearance of a sessile polyp. These are not true polyps and are called a polypoid lesion. As any part of the gastrointestinal tract lined by the columnar epithelium, all types of benign lesions can occur, whether true polyps or polypoid lesions. Studying colorectal cancer causes, the adenoma carcinoma pathway is the commonest. It is responsible for about 50 to 70% of causes of carcinoma of the colon, while the Lynch syndrome mutation root is responsible only for 5% of the cases. It is carcinoma on flat mucosa. The newly discovered serrated pathway is responsible for 30 to 35% of cases. This slide classifies all types of polyps of the colon and rectum. It also applies to the other part of the GIT. Only the neoplastic polyps, or what we call the adenomas, are premalignant. We will discuss the malignant potential of each type of the adenomas in the face-to-face lecture. The polyps associated with inflammatory bowel disease, that is ulcerative colitis or Crohn's disease, or in schistosomiasis, are called pseudopolyps, as they result from regeneration of the destroyed mucosa from the inflammation. These pseudopolyps are not the site of carcinoma, as cancer in inflammatory bowel disease arises from flat mucosa. The newly described serrated polyps are in three types. This is the serrated pathway for cancer. The first one is the non-neoplastic, non-precancerous hyperplastic polyp. The second one is the sessile serrated adenomas. The third one is the rare one. It is the traditional serrated adenomas. The last two are the precancerous ones. They are responsible for about 30% of colorectal cancer. Colorectal polyps are usually silent when they are small, but as they grow, symptoms start to appear. The commonest is bleeding per rectum, whether occult or manifest. They may cause colics if they are big and with long pedicle due to partial intussusception. They may prolapse from the anus if one of them is with a long pedicle and is located in the lower rectum. Sigmoidoscopy and or colonoscopy are the main diagnostic tools, and therapeutic polypectomy is done during this time. In treating colorectal polyps, our aim is to remove all accessible polyps and obtain a clean polyp-free colon. This can be achieved by colonoscopic polypectomy or by surgical resection of the affected colon or transanal resection of the rectal polyps. This will be further discussed in the face-to-face presentation. Please be ready with your questions and the next face-to-face session. Thank you.